Good morning, everyone. Welcome to Grand Rounds. I'm Susan Marshall. I'm covering for Suzanne Mazer this morning, and we're so glad to see you all. So welcome to all of our online attendees. We're inviting you to please submit your questions in the chat, and we will be monitoring those, and then we will go over those at the end of the session today. If you direct your comments to everyone, that would be helpful so we can actually see them. We also want everyone to know that you'll get an evaluation for this conference afterward. It will come from the CME office, and we would really appreciate if you could take a moment to fill that out. It helps us improve our programming and also is really important to maintain accreditation for this educational opportunity. As a last note, planners for Grand Rounds do not have any relevant relationships to disclose. Today's speaker is Dr. Jason Hauptman, and Dr. Hauptman is an associate professor of neurological surgery and a board-certified pediatric neurosurgeon. He's our interim surgical director of the Epilepsy Surgery Program, co-director of the Tuberous Sclerosis Complex Program, and staff neurosurgeon at both Seattle Children's and at Harborview Medical Center. He dedicates a significant portion of his clinical practice to the surgical management of epilepsy, both in children here at Seattle Children's and in adults at Harborview. Dr. Hauptman also has a clinical interest in the surgery of tumors involving eloquent cortex, using techniques such as fMRI planning and awake functional mapping. His research focuses on translation of novel therapeutics to the bedside, including targeted molecular therapies for epilepsy, as well as patient-oriented approaches to improve outcomes in epilepsy and pediatric neurosurgery. Dr. Hauptman received his undergrad degree from Muhlenberg College. He then received his MD from the University of Medicine and Dentistry of New Jersey, which is now called Rutgers Medical School. He went on to complete his neurological surgery residency at the University of California, Los Angeles, under the leadership of Dr. Neil Martin. During this time, he also completed a doctoral degree in neuroscience, studying the cellular neurophysiology of epilepsy in cortical dysplasia and tuberous sclerosis. He then went on to complete his pediatric neurosurgery fellowship at the Children's Hospital of Pittsburgh under the guidance of Dr. Ian Pollack. He holds a certificate in clinical trials from the University of Washington. We're thrilled you're here. Look forward to your presentation today. Welcome, Dr. Hauptman.
Thank you so much for that very generous introduction and for pronouncing Muhlenberg College correctly. You are in the minority of people who get that right the first time. Thank you. It's my pleasure and my privilege to be here to talk to you today. I'm talking to an incredibly important group of people, people who are our primary contacts for all the children that we take care of. Sometimes the only doctor for many of the children we take care of with complex medical issues. So thank you for your service, and I hope that after today you can come away with understanding a little bit more about what we do in epilepsy surgery and how you can help us impact the lives of these kids. I have some consultant disclosures. They have nothing to do with what we're going to talk about today. And this is perhaps the most important slide that I show at the beginning of every talk. Some people like to show the team-oriented slide at the end. I show it at the beginning because it really is the foundation to everything that we do. We have some people in the audience here who I am absolutely privileged to work with in our neurology division. I'm going to call out Steph Randall and Rusty Novotny for supporting the talk here and coming in person. But there's just an incredible group of people. We have multiple epilepsy neurosurgeons, Hannah Goldstein, Jeff Ogeman. We have colleagues in genetics. We have colleagues over at cyber, in radiology, neuropsychology. It's just a lot of people that make all this work happen. So what I'm about to present to you in the next 45 minutes is really what everyone on this slide is doing, not just me. And I just want to make that, sort of abundantly clear. These are the objectives of the talk today. We're going to talk about treatment refractory epilepsy. We're going to talk about why we operate on children with this, what kind of things we see, what kind of surgeries we do, and how we're doing, how we're making these kids after surgery. Just so that we start at the very beginning, okay? How do you get epilepsy under that diagnosis in your EPIC? You get it after having 2 seizures. Why? Because after having 1 seizure, the risk of the second is about 40 to 50%. But if you have 2 non-provoked, non-febrile seizures, the chances in 4 years of having another is nearly certain, between 70 and 90%. That's how you earn the epilepsy diagnosis. That's not enough to get you to epilepsy surgery, but that's the start of the journey. The perhaps most central concept that we're going to talk about today, the most essential thing to take away from the talk, is what is treatment-resistant or medically refractory epilepsy. Those are synonymous terms. Treatment resistance or medically refractory. If a seizure disorder is refractory to between 2 and 4 anti-seizure medicines, the chances of additional medications ending the seizures is less than 5%. If these seizures are associated with a brain lesion, the chances of medicine alone curing the child of epilepsy is even lower. And the fundamental principle that many agree on is that if you continue medication trials beyond the 2 to 4 anti-seizure medicine threshold, unacceptable neurological morbidity will occur due to undertreated seizures. And we'll talk about what that looks like. But it's this 2 anti-seizure medicine threshold is going to be a recurring theme that we're going to talk about in the next few slides. We know that if a child has epilepsy and they have a positive brain MRI, a lesion on that MRI that could explain their epilepsy, they are highly refractory. The chances of anti-seizure medicine alone curing them of their epilepsy is incredibly low. And recently, we've actually changed the definition of medically refractory epilepsy to a 1 medication failure for kids that have positive brain MRIs. What you see in the lower right-hand side of this slide is a Kaplan-Meier curve looking at seizure-free days, whether you have a lesion or whether you don't. And you can see that if you have a lesion, the chances of you being seizure-free over the long term are incredibly low. So, these are the definitions, the operational definitions that we go on in epilepsy surgery. Treatment-resistant epilepsy is a failure of 2 appropriately dosed and tolerated anti-seizure medicines with the intention of achieving seizure freedom. So if you're seizing, despite being on 2 appropriately dosed and tolerated anti-seizure medications, you are treatment refractory. If you have a positive brain MRI, all you need to fail to become treatment resistant is 1 medication. And just for the purposes of definitions, in order to be considered seizure-free on the medication, it needs to be at least 3 times the longest inter-seizure interval prior to starting a new intervention, or at least a year. So if you seize every day, it's not that you need to be 3 days seizure-free to be considered seizure-free. You need to be at least a year. But if you seize once a year, you really should be 3 years seizure-free in order to be considered seizure-free. And yes, these are semantics, but these are incredibly important semantics. Now, as pediatricians in the community, I posit that you are actually in a terrific position to identify these children. In fact, you are likely to identify these children faster and more reliably than their subspecialty providers. Why? Because a lot of times access to their neurologist or other subspecialty providers is limited. In Seattle, we're incredibly fortunate. We have a whole team of incredibly talented pediatric neurologists. If you live out in the Cooley, area, or you live out down in Yakima or Tri-Cities, your access is completely different to pediatric subspecialists. And it's going to be your pediatrician who can easily see in the EMR, hey, you're on 2 anti-seizure medicines and you're still seizing. Hey, you're on 3 anti-seizure medicines, you're still seizing. There may be other options available to you, and we would love if you identify these patients to send them our way so that we can do a comprehensive epilepsy surgery evaluation. Seizures are incredibly common. The incidence of new onset seizures in children is approximately 4 in 1,000, and over 2 years, up to 10% of these children will become medically refractory. even with medical control of their seizures after a year, and approximately additional 10% will become refractory. So up to 20% or more of children with new onset seizures can ultimately become refractory over their lifespan, over their childhood. Okay, I'm going to pivot now. So we've identified who is a treatment refractory patient. So now we're going to talk about, well, okay, why do we operate on these children? And why do we do it sooner rather than later? There is an abundance of evidence that suggests that epilepsy is bad for the developing brain. We know that in children with uncontrolled unilateral temporal lobe epilepsy, greater than 60% of them will suffer intellectual disability. We know that independent of pathology, intractable epilepsy in the first 2 years of life, now we're talking about infants, age 0 to 2, is a significant risk factor for intellectual and sometimes even physical disability. We know that inadequately controlled seizures can result in impairments in cognition, language, social skills, and communication, and can sometimes even look like children are on the autism spectrum, even though it's what we call epileptic encephalopathy. But sometimes those cognitive, psychosocial domains, language domains look very, very similar. And we believe that this is an avoidable outcome, that the epileptic encephalopathy can be avoided by intervening early and relieving children of their epilepsy. We know that suboptimal seizure control results in poorer psychosocial outcomes. We know that these children have lower rates of high school completion, lower rates of continued employment, lower rates of domestic partnerships, and overall socioeconomic productivity. We know that early surgical intervention for intractable epilepsy can result in improved intellectual outcome, improved developmental indices. We can stave off that developmental decline that occurs over the course of the epileptic encephalopathy by curing children of their epilepsy. We know, perhaps better than anything else, that we can also stave off mortality due to epilepsy. And epilepsy is indeed a lethal disease. Many times patients and their parents are under the misconception that epilepsy is simply a chronic disease that has no mortal risk to it. Unfortunately, that is not the case. Sudden unexplained death secondary to epilepsy can occur at rates of 0.5 to 1% per year, cumulative, over the course of the disease. Cumulative. Let that sink in for a second. A child who is medically intractable for 10 years can have a 10% risk of death. That is incredibly high for what would be considered essentially a benign childhood disease. It is not a benign childhood disease. And that's just SUDEP. That doesn't include other risks such as trauma, having a head injury from falling from a seizure, or potentially losing consciousness and aspirating and ending up with an aspiration pneumonia. This study is literally hot off the press. This was published in The Lancet this last month. This is my friend and colleague, Sandy Lamb, out of Northwestern. She looked at the FIZ database. She had something like 18,000 children she was able to identify who had a diagnosis of intractable epilepsy. She did a beautiful job in this study, 18,000 kids. She found that surgical intervention, whether it be a definitive surgery, which we'll talk about what that is, or a palliative surgery like a vagal nerve stimulator, and we'll talk about that too, the risk of mortality is significantly lower in the surgical cohort compared to the medical alone cohort. Very compelling data, 18,000 children pulled out of about, they identified something like 170,000 kids, and they narrowed it down to 18,000 who they were able to get good, reliable data on that they were medically refractory. This is very compelling evidence that epilepsy surgery reduces the mortality associated with intractable epilepsy in children. This was a pediatric study. There is room for improvement here. This is a now very, very well-described survey that's over 15 years old, done by Harvey et al., published in Epilepsy, actually, when I was a resident. And it was a survey of all pediatric epilepsy centers internationally. And on the left-hand side, what you see is how old kids were when they started seizing. These are kids that were ultimately referred to a pediatric epilepsy unit, okay? So kids who were ultimately referred to a pediatric epilepsy surgery unit, the vast majority of them started seizing between 1 and 2 years of age, okay? That's when the epilepsy started. On the right-hand side is how old they were when they got referred. Those two graphs should look the same, but they don't. They look completely opposite. Even though the majority of kids started seizing in the first 2 years of life, the majority of them were not referred for epilepsy surgery till their late teenage years. It took over 10 years or longer on average to get a child from being intractably seizing to being identified as medically intractable to being referred to a pediatric epilepsy surgery unit and to getting a definitive intervention. So we can certainly do better, and that's something my colleagues and I have been working really hard at doing, and this is where you guys come in, because it's early identification of these kids that makes all the difference in the world. And I would argue that it's the lack of early identification of these children that is the biggest holdup in getting them in the epilepsy surgery pipeline. If you don't know you're intractable, you don't know you're a surgical candidate. And patients, they don't know. They don't know. And many of them are out there lingering on 2 or 3 ASMs and inadequately controlled. Okay, I'm going to pivot again. We talked about who could be a candidate, why we intervene early. Now I'm going to talk about the kinds of things we see in epilepsy surgery. This is also from that same survey that I just described, and they asked the centers to describe the most common things they were seeing. By far and away, the most common etiology we see in pediatric epilepsy surgery is cortical dysplasia. We'll talk about that. Followed by tumors, and then followed by more rare conditions. Cortical dysplasia is essentially a disease in which there is a birth-related migrational abnormality of the nerve cells. At the beginning, when the brain is developing, neurons are migrating from the center of the brain, right below the ventricles, out to the surface. They have a molecular map telling them where to go, how to be aligned, where to point, where the white matter should be, where the gray matter should be. In cortical dysplasia, those molecular signals are aberrant. And these neurons end up in the wrong places, pointed in the wrong direction, just absolutely confused. Sometimes when it's severe, not only do the nerve cells end up in the wrong place, but they end up being immature, sometimes incompletely developed. Cortical dysplasia is not a tumor, it's a static lesion. It doesn't change over time. But these nerve cells are in the wrong place doing the wrong thing and ultimately cause seizures. We know that more severe cortical dysplasia is more common when children are younger. We know that only about half of children with cortical dysplasia have a positive MRI. That means half of cortical dysplasia is microscopic. It's beyond the resolution of our MRIs. And sometimes the only way we find it is by doing epilepsy surgery for presumed cortical dysplasia and looking at it histologically and making the diagnosis. FDG PET has been very helpful and can sometimes identify up to 90% of cortical dysplasia cases, even when the MRI is negative. But there are times where both the FDG PET and the MRI can elude us. Focal cortical dysplasia is most commonly found in the frontal and the temporal lobes, but can be found anywhere, and we've seen it anywhere. This is the most recent classification. This is a histological classification. The only thing I would take away from this slide is that we typically think of the histological abnormalities of cortical dysplasia as being either type 1 or type 2. Type 1 is where the nerve cells are confused, they're turned around, they look a little funny, but not super funny. Type 2 is where the nerve cells are completely turned around and look really funny. They have these cytomegalic interneurons, they have these things called balloon cells. I can look at the microscope and identify it as looking abnormal. That's how abnormal it is, and I'm not a pathologist. Ironically, the type 1 cortical dysplasia is the bigger problem for us in epilepsy surgery. Type 2 cortical dysplasia, because it looks so abnormal, we usually can identify it on MRI, and we usually can identify the surgical margins of it pretty easily. And so our cure rates for type 2 cortical dysplasia are really high. Type 1 cortical dysplasia, because it's so subtle sometimes, so hard to detect on an MRI, we have to use a lot of different techniques to describe the boundary of what we think the cortical dysplasia is, and our cure rates are lower for that reason. Type 3 is when cortical dysplasia is associated with something else, like a tumor or vascular malformation. Low-grade tumors like DNETs and gangliogliomas are very common in what we see in our practice here. They are low-grade, slow-growing, and they have very high cure rates for their epilepsy when they're resected. Sometimes we'll see things like perinatal infarcts. Hippocampal sclerosis, or what we call mesiotemporal sclerosis, is the most common reason why adults get epilepsy surgery. It is one of the least common reasons why children get epilepsy surgery. The cure rates for hippocampal sclerosis in adults are actually quite high. We have, as part of Dr. Randall, Dr. Novotny, and their partners' practices, a fairly large Sturge-Weber population. This is a rare disease. It's angiomatosis that affects an entire hemisphere. These kids generally have a port wine stain. It's very recognizable. And they generally will develop progressive hemiparesis due to the angiomatosis of the affected hemisphere, and it causes essentially what are likely microinfarcts, and they calcify over time. Some of these kids will develop terribly intractable epilepsy, and we will do dramatic surgeries like hemisterectomy and cure them. Dr. Randall, over the last decade, has built an incredible tuberous sclerosis center here, and we have a large number of children that she sees from all over the West Coast and beyond who have this debilitating disease that consists of intellectual disability, facial angiofibromas, seizures, and cortical tubers, which is what you see here. These are not tumors, these are hamartomas, and they cause medically intractable epilepsy. And they cause significant developmental decline when that epilepsy becomes highly refractory, which it does many times. A lot of these kids will benefit from multi-stage surgery, including invasive electrical recordings, followed by removal of the offending tubers. This is a very challenging disease to treat. This is a lifelong struggle with epilepsy for a lot of these kids, and sometimes multiple operations. But we can make these kids' lives a lot better by reducing their seizure frequency. Rasmussen's encephalitis is a rare autoimmune condition. We probably see 1 a year, maybe 2 a year. It's progressive hemiparesis that leads, and intractable epilepsy that leads to basically atrophy of the affected hemisphere. In current state, the only known cure for Rasmussen's encephalitis is a hemisterectomy, is disconnection of the affected hemisphere. There are some interventions we do that buy time, like plasmapheresis or immunoglobulin therapy or steroid therapy, but they only temporarily work, and these children almost universally go on to hemisterectomy. Perhaps one of the most interesting things that we see, and we see a handful of these a year, is the hypothalamic hamartoma. Hypothalamic hamartomas are hamartomas, they're not tumors, they're in the hypothalamus, as the name suggests. They cause some very unique forms of epilepsy that can be highly refractory. One is called the gelastic seizure, which is uncontrolled laughing fits. But these laughing fits are without euphoria. They're without mirth. And so when a child has a gelastic event, it's uncomfortable for them. They will describe it as, I feel the urge to laugh, I do not want to laugh. It forces me to laugh. And sometimes it can be in very inappropriate situations, as you could imagine. And so those gelastic seizures are quite problematic. There's another seizure called a dacrystic seizure in which children will scream or make like a shrieking, screaming, grimacing thing. Also, it doesn't have that emotional component. They don't want to be doing it. Some of these kids will develop other forms of epilepsy concurrently or after the onset of the gelastic events that also can go on to be highly refractory. The game changer for hypothalamic hamartoma has been something called laser ablation, which is a minimally invasive surgery in which we put a laser probe in the hypothalamus in the hamartoma and we burn it in real time. It used to be that you had to do a big open craniotomy and had significant morbidity associated with it. We've come a long way in treating these kids, and we see quite a few of these kids. I'd say we have a pretty sizable hypothalamic hamartoma practice, and sometimes kids will travel from other states to see us here. And then there are some other, that's interesting. There are some other uncommon etiologies that we see here because we see a lot of kids, like hemimegalencephaly, which is where the entire hemisphere is one large cortical dysplasia, Landau-Kleffner, which is an epileptic aphasia, and then polymicrogyria, which we see actually a fair amount of. Okay. We've talked about who's medically refractory, why we intervene early, what kinds of things we see. Now let's talk about what we do, what kinds of surgeries we offer. Central to any pediatric epilepsy program is this pre-surgical pipeline, which requires interdisciplinary coordination, quite a bit of it, to the point where we have navigators that help our patients navigate the journey through epilepsy surgery because they need multiple providers involved. We have our neurology colleagues who essentially are managing these children, are getting them all their tests arranged, including things like video EEG, neuropsychology, multiple imaging tests. We have, our surgeons that are helping with our neurology colleagues evaluate the patients and determine the best surgical approach. We have our neuropsychologists who are doing pre and post assessments to see how we are doing, what areas of the brain are being affected, and are we helping. Video electroencephalography is central and essential to identifying these patients, trying to what we call lateralize which hemisphere it is, or localize where in that hemisphere the seizures are coming from. Our neuropsychologists they have an impossible job that they do incredibly well, which is do multi-hour batteries of tests in 5-year-old and 6-year-old children. I mean, I can barely sit through an 8-hour test. The fact that they can do that in children who have comorbidities like ADHD or on the autism spectrum or are heavily medicated, I give them an incredible amount of credit. Their testing is essential to what we do. Why? Because they identify areas of the brain that are dysfunctioning prior to surgery, and then they test them after surgery to see how they're doing. Are we improving? Are we stabilizing? Are we worsening? Because central to everything we do in epilepsy surgery, we want to make these kids better. We do not want to make them worse. And we don't want to take away their epilepsy at the cost of function. That is central to what we do. And so they help us achieve that goal. The structural high-resolution MRI, we do 3 Tesla MRIs as routine here. There will probably come a time where we even do higher field strength MRIs. These MRIs are essential for identifying anatomic abnormalities. Having MRI positivity is incredibly helpful to us as surgical epilepsy physicians. If you have a positive brain MRI, that points us in the right direction. If you have a positive brain MRI, that helps us identify the boundaries of what we might need to resect or disconnect. If you have a positive brain MRI, the likelihood of you being seizure-free is higher. The better we can see the pathology, the better we can treat the pathology. And here you see a potpourri of MRI findings ranging from Sturge-Weber in the upper left-hand side to Rasmussen's, which is third from the left on the bottom, to low-grade gliomas, like what you see on the right-hand side of the screen. all of these children could be pediatric epilepsy surgery candidates. Sometimes the MRI, the structural MRI, can be obscure. This is where ancillary imaging can be very helpful. FDG PET looks at how the brain metabolizes glucose. We know that during a seizure, the brain is really metabolically active. In between seizures, what we call interictal, in between seizures, that area of the brain that is incredibly active during the seizure is out of breath and is actually hypometabolic. And so we look for interictal hypometabolism. We try to do these PETs when kids are not seizing. We're not always successful. Some kids are having incredible numbers of seizures that they're actually seizing during the PET. But if we can capture them in the interictal state, we're looking for cold areas. Those cold areas are highly correlating to areas of focality for epilepsy. And like I said earlier on, for cortical dysplasia, which is the most common thing we see in pediatric epilepsy surgery, having a cold PET scan can be incredibly helpful to us. Our colleagues at Harborview are able to do what's called an ictal SPECT. This is where a radionucleotide is injected at the time of a seizure. So you have patients, you're waiting for them to seize. As they start seizing, you inject them and you get them in the scanner. And the area that is active for the seizure will light up. You can imagine that in a child, this is difficult. In an adult, this is difficult too, but it's less difficult than in a child. We sometimes will ask our Harborview colleagues to assist us by performing this test, but it really requires an older child there's a lot that goes into it, but there's a lot of barriers to getting this in young children. So the PET is usually more helpful to us than the SPECT. When it comes to surgical approaches, there are a wide array of options for children. And what's been incredible is that in the last decade, we've developed a lot of new options that didn't exist before. And what this has allowed us to do is it's allowed us to expand the pool of children we can help. There was a time where our focus was incredibly narrow on a very sub-select few children who we knew we could cure. Now, and perhaps this is the most important thing that I'm going to say today, now any child with refractory epilepsy has a surgical option. Any child has a potential for either a curative approach or a palliative approach, where we reduce their seizures but perhaps do not cure them. Every child has an option. And again, bringing it back to the beginning for everyone that's on the call, this is where you come in. If you can help us identify these children early on, we can give them the options early on, and they can reap the full benefits of our approaches. Because again, like we described at the very beginning of the talk, the earlier we intervene, the better off these kids are. And so this is where we ask for help. Sometimes we have to better localize where the seizures are coming from. The MRI might give us the state or the zip code of where the seizures are coming from. We want to know the seizures are sitting in the armchair of this particular house on this particular street in Matthews Beach. To get that information, we might need to do a surgery where we implant brain electrodes. We call it stereoelectroencephalography. It's minimally invasive. It doesn't even require us cutting the hair. Incisions the size of my pinky fingernail, and a robot that allows us to very precisely place these brain electrodes in areas where, as a group, our neurology colleagues, our neurosurgeons will sit down and say, these are the areas of the brain we want to put electrodes, this is where we're going to do it. We'll park kids in the hospital for a couple days, wean them off their medicines, have them have a few seizures, and localize exactly what armchair in what house on what street in Matthews Beach these seizures are coming from, so that we can tailor a surgical approach to that precise area. Sometimes we'll put grid electrodes on the surface of the brain. That can be super helpful too. It allows us to cover a large area and allows us to map important brain function to brain regions like language, movement, and sensation. When it comes time for definitive surgeries, sometimes we will remove or disconnect a lobe. Perhaps the most well-described and perhaps the most common surgery in adults is a temporal lobectomy, and it is incredibly effective. The best study that's ever been produced out of epilepsy surgery was published in the New England Journal of Medicine, and it showed a significant difference in adults with intractable epilepsy treated with temporal lobectomy versus medication alone. Up to 75% of these patients were cured of their epilepsy, and it was durable. Sometimes we will take either parts of a lobe or an entire lobe outside the temporal lobe. This is a cavernous malformation causing epilepsy that was resected in the frontal lobe. Sometimes we need to do awake surgery. Why awake surgery? Awake surgery allows us to precisely map important brain function in real time. If a child has a lesion near their language area, near their movement area, it gets back to what I was saying earlier. We want to cure the epilepsy and we want to give the child back to their parents in the same condition their parents gave their child to us. Doing an awake surgery allows us to very carefully tailor what brain regions we think we can disconnect or resect safely and which ones we need to spare. And it's incredibly effective. Believe it or not, it is painless for children. We completely anesthetize their scalp. Their brain itself feels no pain. And they're awake and they're talking to us while we're very gently stimulating the brain surface. There was a case a few years ago that got a little bit of media attention for a young girl named Kira who sang during her surgery, but this is something that's been around for a long time, that we've been doing for many, many years. Laser ablation, MR-guided laser ablation, is the newest resective strategy we have in the surgical arsenal. Using a probe smaller than a pencil point and an incision the size of my pinky fingernail, we can place a probe very precisely in areas of the brain that we want to disconnect or resect and apply heat to it in real time in an MRI scanner with the child asleep. This can allow us to achieve the same effect as removal or disconnection, but completely minimally invasively, without even cutting the hair. These kids frequently will go home the next day. And for deep brain structures, like the hypothalamus, like that hamartoma I was telling you about, or the mesial temporal lobe, which is what you see on the left. So left-hand side is mesial temporal lobe, right-hand side is hypothalamic hamartoma. That's what it looks like in real time when we're doing the MR-guided LIT. We are transforming the care of these kids. The old way of doing the hypothalamic hamartoma was a big craniotomy. You would have to resect part of the hamartoma. You'd get up against the hypothalamus, and these kids would be in the hospital for days. Now these kids go home the next day. Perhaps the most dramatic of all the surgeries we do is the hemispherectomy. The hemispherectomy is as it is described. It is disconnecting half of the brain. Why do we do it? We have a lot of children that have catastrophic unilateral hemispheric epilepsy. It can be from Rasmussen's encephalitis, which is that autoimmune disease I presented to you earlier. It can be from cortical dysplasia that affects the entire hemisphere. It can be from a stroke, a trauma. There's a lot of different reasons. These children typically are having many seizures and are very developmentally affected from that abnormal hemisphere. It is the most gratifying surgery that we do. The cure rates are upwards of 70 to 90%, and they're durable. And many times, ironically, you would think disconnecting the entire hemisphere would debilitate a child. Many times it doesn't. In fact, the younger you do it, the less likely you will be able to ever tell that it was done to that child. You would think they would be hemiplegic on that other side for the rest of their life. They're not. Within a year, they can learn how to move that entire side, how to walk, how to run, how to throw a ball, how to catch a ball. And once that hair grows back, I challenge you to be able to tell that they even had a hemisterectomy, which is incredibly wild. Not only did they get to learn how to use that side again, but they could potentially live their entire life seizure-free after having hundreds of seizures a week. There are many different ways to perform a hemisterectomy. There's a lot of evolution that's occurred with this operation over the years. We do a variant of the one in the middle, which is we disconnect the half of the brain from the other half. We don't remove it all. You don't have to remove it all. You just need to you need to find the I-5 and the I-405 and the I-90 that connect the two halves and disconnect them. That's what we do. These are the different ways it's been described. Like I said, we do the functional form, which was the middle. Corpus callosotomy has been around for a very long time. That's where you disconnect that big white matter band between the two hemispheres called the corpus callosum. It's been around since the 60s and 70s. It fell out of favor for a bit, but we're starting to think about it again. Why? Because we can do this with the laser too. Corpus callosotomy is very, very effective for children who have what are called drop attacks, which are severe seizures in which all muscle tone is lost instantaneously. Just close your eyes and imagine what that must be like. You're standing and then immediately you lose all muscle tone, and then imagine hitting your head from that. So a lot of children who we offer callosotomy to have had severe craniofacial injury from these atonic seizures. And it's highly successful. You can get 70 to 90% reduction in atonic seizures following callosotomy. And now that we're doing it with the laser, it's again minimally invasive. It used to be able to do a big open surgery, big open craniotomy, and dissect between the two hemispheres. And now we're doing it through these minimally invasive approaches with not even cutting the hair. The one thing that comes with the callosotomy is something we call the disconnection syndrome. It varies in severity, and it sometimes requires rehab. So some of these kids may stay with us for a few weeks while they learn their balance again, get back on their feet, and then sometimes they need some help eating again. And there can be a temporary period of time where they have a G-tube. But in the end, it's worth it because these atonic seizures are absolutely debilitating. The newest addition to the armamentarium for us as surgeons is what we call neuromodulation. I'm sure a lot of people who are on the meeting today have heard of the vagus nerve stimulator. That one's been around for a while. It's the only non-brain surgery brain surgery that we do for epilepsy. It's a stimulator that's implanted in the neck and the chest, and it intermittently stimulates a vagus nerve, which is a cranial nerve that goes all over the body. And it's been shown to reduce seizures by about 50% in about half of kids. Almost any child with refractory epilepsy can get a vagal nerve stimulator. And even though it won't cure them of their seizures, it can significantly improve their quality of life. And recent evidence has shown that it reduces their SUDEP risk. So it reduces the risk of mortality secondary to epilepsy. The newer techniques that we're employing include something called deep brain stimulation and something called responsive nerve stimulation. Deep brain stimulation has been around for over 20 years. It was originally designed for older patients with Parkinsonism, and it's done an incredible job transforming the care of those patients. We are now using it in children and adults with epilepsy, and again can reduce seizures by 50 to 60%. It is essentially a brain pacemaker, and it's placed in the thalamus. The newest of all the different neuromodulation techniques is responsive neurostimulation. It goes by trade name NeuroPace. It is an implanted computer that essentially will process brain electrical signals in real time. We put in 2 wires. It's constantly reading brain activity, and when it detects a seizure, and we help it learn what a seizure looks like, it will gently stimulate the brain and abort the seizure. We just did one of these surgeries yesterday in a young child who has had multiple epilepsy operations and continues to seize, and I am incredibly optimistic about how it's going to help her. This is an overview, again, of these neuromodulation techniques, and you can see they work. After 2 years with a DBS, there's a 56% mean seizure reduction. After 8 years with an RNS, with NeuroPace, there's a greater than 66%. There's a greater than 50% seizure reduction in 2/3 of patients. It works. It's durable. Very effective. Outcomes. We'll end on this. After epilepsy surgery with an intent to cure, up to 80% of kids can be seizure-free. If they have a temporal lobe resection, they have the highest rates of seizure freedom. And we know that if they're seizure-free early after epilepsy surgery, for the first 6 months, there's a greater than 95% chance they'll be seizure-free for the rest of their life. In up to 50% of kids, they can come off their medications completely. And for those of you who take care of kids who are on anti-seizure medicines, that is a primary driver. No one loves being on these medications. They have side effects. We know that focal resections do better than, can do really well if they localize with the MRI and electrically. We know that the more widespread or diffuse, the lower the seizure cure rates. And we know that if the MRI is negative, it gets harder for us to cure. We can still do it, but it gets harder for us. Complications following epilepsy surgery are low. They are much lower than the natural history of epilepsy. Mortality risks following epilepsy surgery are less than 1%. Unexpected morbidity is also less than 5%. The SUDEP risk of the child with intractable epilepsy is 2% in 2 years. It's 5% in 5 years. So the way I describe this to parents is one epilepsy operation with the chance of curing their child has about the same risk of living with the epilepsy for 2 years. It's just packaging it up and absorbing it at one time. In general, we think that these risks are lower than the risk of treatment-resistant epilepsy. We know that following surgery, developmental quotients improve. Caregiver assistance levels go down. That makes it easier for parents to take care of their children. Behavior, attention, IQ scores improve. We know that there's better school performance, better social adaptation. I mean, I can go on. We know, this actually probably one of the coolest studies that was done, they took children with temporal lobectomy and they compared them to age-matched controls that didn't have a temporal lobectomy, that were totally normal kids. Quality of life indices in kids who had temporal lobectomy normalized to their cohorts in 3 years. It's as if they didn't have the disease, ever have the disease. That's pretty cool. That's what we're going for. We know that following surgery, kids have greater feelings of self-worth, social competence. It allows their parents to go back to work or go back to school. We know it's cost-effective. We know that epilepsy surgery costs less than a lifetime of anti-seizure medicines and hospital admissions. There's just a lot of compelling reasons to do it, and I'm trying to condense them all into like 3 slides. At the risk of sounding evangelical about it, it works. It works. I just want to make a little plug for some of the research that people in this room are doing, as am I. The next generation of therapy for kids with intractable epilepsy is going to be molecular genetic. We are identifying abnormal genes in kids who have brain surgery for epilepsy. Due to some terrific work that Rada Mirza, one of our colleagues in genetics, has done, with Bill Dobbins and Philomena Perozzi and some others, we know that the mTOR pathway in particular is affected in probably more than half of children who get epilepsy surgery. It just so happens that drugs that affect the mTOR pathway, like ones that Dr. Randall uses routinely in the TS clinic, are available clinically for use. We have a trial that we just closed here in which we tried an mTOR inhibitor in children who failed epilepsy surgery. These are kids who are at the end of their road. And we have found that in some kids it works. One child, P06, had a hemispherectomy a bunch of years ago and started seizing from the good hemisphere. Turns out she has a mutation in AKT3, which is upstream of mTOR. It also turns out that when we treated her with an mTOR inhibitor, she went from having 100 seizures a week to being seizure-free. She has been on the open label extension for this drug for now close to 3 years. We started this trial my second year here. She's in red. She's been seizure-free for 3 years. She was having 100 seizures a week before starting this drug. Now, of course, this is not going to be the result of every child on this medication, but it's proof in principle that future state is identifying these genes of interest and leveraging therapies that we already have. A lot of them are being used in the oncology world and using them to target these abnormal molecular pathways and potentially either benefiting kids who wouldn't have gotten epilepsy surgery in the first place or fail epilepsy surgery afterwards. So I'd like that to be food for thought, and I want to close with that and leave a few minutes for questions. I really appreciate you letting me talk to you guys today, and I hope that everyone comes away from this learning something. Thank you.
Dr. Hoffman, thank you so much. This was absolutely phenomenal. I learned so much, and it's really inspirational work. I'd like to ask in the audience if anyone has any questions, and I'll bring around a mic. And while people are thinking of questions, I was really struck by the fact that after this surgery, there actually is not just a stabilization of cognitive and psychological and other things, but actually some improvement. I'm wondering if you could speak a little to that, because I think to those of us who are pediatricians, that's really, really phenomenal.
So, I think the answer is we don't know the answer, right? Because part of it is the brain that we are disconnecting or resecting is bad brain. Part of it is the seizures are bad. And then part of it is the medicines we use to treat the seizures also have global cognitive effects. And so it's a combination of all three of those things that can result in either stabilization or improvement. But you could just imagine, the way I like to think about it is imagine trying to do college level calculus with static in the background on volume 11. It's impossible. But if you turn that static off, all of a sudden you're doing calculus. And so I think that there is a complex interplay of removing the offending lesion, removing the epilepsy, and removing the medications to treat them that ultimately will benefit the patients in the long term. Yeah.
Questions from the audience?
He has all the answers.
Jay, so as you mentioned, a lot of the new neuromodulation devices, and I think one of the aspects that I think is really important is that these devices, as you know, for the deep brain stimulation have been around for 20 years. The safety in adults has been here. And then the newest device, the responsive neurostimulation, is I think it really needs to get into the pediatric realm. As you know, there are ongoing trials to try to get this FDA approved down to age 12. The vagus nerve stimulator, which has been here 20, 30 years, is down to age 4 or 2 now, but it takes a long time. How do we get these devices in earlier, and what are the long-term benefits are we seeing? Not only from our adult colleagues who've had some of these devices in for decades already, but what are the mechanisms that we need to sort of get these patients into this new realm of treatment?
Thank you for that excellent planted question, Dr. Novotny. So, as Dr. Novotny accurately stated, the barriers that we have right now to neuromodulation in children are not from the providers, they're from the payers. We have had success here implanting both DBS and RNS in children as young as, the youngest DBS I think I've implanted now was 5 years old. Was not for epilepsy, actually. It was for Lesch-Nyhan disease. That's an interesting total side topic. It was for Lesch-Nyhan disease, and it was incredibly effective. Different story, but the payers are definitely the challenge here. There's a coordinated effort nationally to push the payers to reimburse for these therapies. Now, to answer that multifaceted question, what we're seeing is that reduction in seizures is clearly better for the children. It's better for them neuropsychologically, and it reduces their SUDEP risk. And I would say that the reduction in SUDEP risk is enough. It is enough to justify treating these kids. If you look at the bottom, in kids who are surgical candidates, their SUDEP risk is somewhere between 6 and 9 per 1,000 patient years incidence. In kids or adults with DBS and RNS, it goes down to 2. That is very significant. That in and of itself is justification for doing this. But we are also finding that less seizures are not only good for the kids, because it results in less medication, it results in less days of school missed, less days of work missed. There is a caregiver component to this that is really important. Now, whenever any of us see patients and their parents will universally never put their own needs in front of their child. And so they will not consider themselves in that equation. But it's incumbent on us to think about that. And we talk about this with parents. My kids are teenagers now. They're getting older. They're getting bigger. I'm getting older. If my child has intractable epilepsy, my ability to take care of them will decrease as I get older. It is important for the caregivers to reduce the burden of epilepsy so that they can continue to take care of their children. You could imagine when a child is 3 and they have a drop attack, and I'm in my 30s, I can pick my 3-year-old up. When my child is 18 and weighs 200 pounds, and I am in my 60s, picking him up after an atonic seizure is going to be a lot more difficult. It may require me to call an ambulance. It may require me to take my day off of work. Those are very compelling reasons to do palliative therapy. We have to keep our parents taking care of their children and not hurting themselves by doing it. We have to keep our parents working. We have to keep our parents taking care of their other children. And those are really important variables that have to be in the calculus. And that is where palliative therapy shines. And it is incredibly rare that we will meet a parent whose child had a palliative intervention who wasn't feeling very optimistic and fortunate that they had it done. And that, I think, is the reason why we do it. And there is some early evidence that suggests that combining palliative therapies may be more effective than just one. So for instance, VNS, which is the non-brain surgery, adding an RNS onto a VNS may actually be more effective than VNS alone. There's a little more work that needs to be done there, but early data suggests that it's helpful. It's going to reduce the SUDEP risk. It's going to reduce the number of seizures. It's going to stabilize the medical therapy. It's going to potentially stabilize neurocognitive decline. And it's going to keep parents working, going to school, taking care of their other kids.
Thank you so much. With that inspirational ending, I am going to close Grand Rounds for today. Thank you all for attending. Wishing you a good week. You'll see evaluations coming your way soon. Thanks, everyone. Thanks, Dr. Hautman. Appreciate it.